Hello, everybody. My name is Jose Maria Chema Valderas. I'm the chairperson of the Working Party in Quality and Safety, and it is my pleasure to be here with you to give the third webinar in the series on the PaRIS OECD report survey. We have previously had webinars from Jandan Kendir in relation to the main results of the survey. We had a subsequent seminar with Zelika and with Bohumil in relation to, from the perspective of two specific countries, Slovenia and the Czech Republic. And this one is about the development of the survey and what actually the PaRIS survey is measuring. So it's an extension of the previous two, and also one that helps you make sense of the of what is actually being measured as part of the survey. I have to apologize that there was a previous announcement of this webinar, and for technical issues it was not possible. So thank you very much for finding the time to joining us today. Also to let you know that we're also recording this webinar and will be available on WONCA's and our YouTube channel as well. So without further ado, I will now start sharing my presentation. Thank you. The title of my presentation is Measurements Behind Patients' Voices, PROMs and PREMs in the Economic Cooperation and Development OECD PaRIS Survey. I am, for your information, apart from my role in WONCA as chairman of the Quality and Safety Working Party, I'm also a professor of medicine, head of Department of Family Medicine, and director for the Center of Research in Health Systems Performance at the National University of Singapore. So this is a brief reminder of why there is a PaRIS survey in the first place. You may have seen this slide previously. Okay, I'm here both. Apologies if on occasion you see me stuttering and having my attention distracted, because I'm also here welcoming and admitting all the participants. So basically, you may have seen this before. This is the rationale for the PaRIS survey. And I said you may have seen this before. So what the OECD basically aimed to explain, to enrich their already very strong set of indicators of health system performance with indicators that were reported by patients. So it's all very good to have indicators of, let's say, funding dedicated to health and healthcare, on hospital admissions, length of stay. But at the end of the day, you also want to be able to say how the system is responding to the users, to the patient's needs. And this is how the some of the issues that the survey was expected to deliver were phrased. And what I think is important is that previously, when we had presented this slide, we were making focus on diabetes programs in the first question, or cancer in the second one, or let's say multiple chronic conditions in the last one. And what we are highlighting here is that the focus is really how people perceive both their health and how the services that they have received. And this is the core and the core of the survey, and the very rationale why the OECD developed this survey. Okay. So I'm talking here on with multiple roles. not just obviously as chairman of the Working Party, but also because I had previously been in a previous role as president of the International Society for Quality of Life Research. I had been part of the task force that the OECD had set up for scoping the PaRIS survey. And as part of this scoping exercise with a number of experts, it was agreed that what was necessary was a survey of individuals aged 45 and older living in the community with at least one chronic condition and with experience of use of primary and ambulatory care in the previous 6 months. And that there would be also an accompanying questionnaire for providers working in primary care and ambulatory care. So basically having the perspective of both the patients and the healthcare professionals. And healthcare professionals working in all these very many different systems, which we're presenting here for multiple reasons. Because the evidences, first of all, that we will be dealing with primary care / ambulatory care across a variety of health systems, some of them with very clearly defined boundaries between primary care and secondary care and specialty care and tertiary care, and others where these lines are a lot more blurred. Hence the descriptor of ambulatory care, because for some of them the attribution to specific primary care was a bit more difficult. But also because, as you can see here, many of these countries are European, and to some degree they follow one or two main approaches. On the one hand, you would have national health systems, on the other one, insurance-based, mandatory insurance-based systems. But that would be most of the European countries. However, we also have Australia, Canada, Saudi Arabia, the United States, Israel. So not only a variety of health systems, also a variety of people, a variety of socio-demographic contexts, a variety of languages. All these made the effort quite substantial and explain that from day one, the focus was on a collaborative effort to ensure that the survey, the measurement, and the results would be applicable across a wide range of context. Okay, so what I will be presenting therefore is three main aspects. One is the first question is really what do we want it, what we thought it was necessary to be measured. So, and that's what we will present as part of the framework. There's a core conceptual framework for the PaRIS survey, what to measure. Secondly, we will go on to see how to measure what we had already identified as a priority to be measured. So that would be what instruments were used, were identified as part of a structured and replicable, as much as possible, replicable process. Finally, we also needed to put all this together in a survey. So integrate all these instruments in a coherent single tool for administration, for patients, but also one that would work across all these close to 20 countries, many of them with multiple languages and different expectations for people in relation to the health and healthcare. So these will be the three parts of the presentation. So in terms of the development of the framework, we started with the OECD framework for measurement of quality of care. And this is that framework was published in 2015 at the International Journal of Quality of Care. And what you can see here is that, I mean, there were three main broad dimensions of healthcare systems performance. One was from right to left, cost and expenditure, access, and then a broad category, which was quality. And between quality, there was a differentiation between effectiveness, safety, and responsiveness and patient-centeredness. And it was within these aspects that we were particularly interested in operating for the PaRIS survey. Also on your left-hand side, you can also see the different types of healthcare needs: primary prevention, getting better, living with illness or disability, chronic care, and coping with end of life. So, but useful as it is, it was clearly fell short of the detail that was needed for identification of the core aspects that needed to be measured. So we aim to enrich this framework with identifying previously a priori some frameworks that we thought were relevant, and we did that with as proposed by experts. So as proposed by a large number of people. So that would be the Working Party in quality in health at the OECD, but also the Secretariat, also the consortium that was commissioned with development of and administering the survey, but also other groups of people which involve a technical advisory committee of experts, and also a patient advisory group as well, which was comprised of patient representatives. So all these people contributed to help us identify a priori a number of frameworks. And then we moved on to actually aim to identify systematically additional frameworks for the purpose of the survey. So they had to be in relation to primary care, or focus on chronic care, on patient-reported outcomes, or more broadly in relation to health systems performance. And this is just the summary of that combines all the different systematic efforts to compile information into one. And we identified basically 64 relevant documents that corresponded to 62 different frameworks. So with these 62 frameworks, and based on the original that I presented to you at the beginning, the one published in 2015 by the OECD, and through a narrative symptoms and constant comparison of each of the domains and subdomains in the identified frameworks, we paid attention to a number of criteria to try to enrich the previous framework and develop the updated one. So all these different domains, the different aspects of care that we wanted to measure, needed to be part of a coherent set. So there needed to be some internal logic to it. Also, we wanted to minimize the overlap between characteristics because we wanted a parsimonious set. A recurrent issue in developing such a complex instrument is that people are, and reasonably so, worried with the burden of administration that will imply for respondents, and the implications for response rates, but also generally for the sustainability of the efforts. So we wanted to minimize that the overlap. We also wanted support in the literature for the different domains, and we wanted to minimize the number of different domains without significantly compromising comprehensiveness. A really difficult act. And finally, we wanted to have these domains aligned with the previous recommendation from the task force I made a reference to. So with the groups that I previously mentioned, we developed a draft framework through an iterative process, refined it with sustained engagement with the International Patient Advisory Panel, the International Multidisciplinary Technical Advisory Committee, and also with oversight by the International Working Party of OECD member states. We were not satisfied with that, and we also wanted individual patients, not just the representatives, to be part of these efforts. So we organized a number of international virtual patient co-development workshops. And by now, it may seem not a particularly groundbreaking idea, but this was actually designed. I mean, the whole project started on the 1st of February 2020, so literally within days of the start of the declaration of the COVID pandemic. So obviously everything needed to be moved quickly to Zoom, but the good news for us at that point was that we already had considered developing these patient co-development workshops as a virtual effort. And there were good reasons for this, because we wanted to revisit the scope, identify gaps, minimize overlap, and ensure consistency of terminology that would be in line with patient preferences. But we also wanted to start confirming the applicability of this framework across a wide number of countries. So that's why we organized the workshops by language, not by country. So we had all in all 22 participants in 3 languages, English, Spanish, and German, across 7 countries: Australia, Austria, Canada, Chile, Germany, Mexico, Spain, Switzerland, and the US. And it was they came up with very interesting and relevant recommendations, all of them, one way or the other, eventually made it to the to resulted in changes to the survey. So additional symptoms were we were encouraged to consider, also to consider financial aspects of care, to ensure that there was measurement of trust in the healthcare professional, that there were metrics of achievement of goals and expectations for the individual patients, support to self-management, consideration to the multiplicity of ways in which interactions between healthcare professionals and patients could take place. Something that increasingly was becoming aware as we progress through the pandemic, and people that really needed to adapt to a different situation in terms of accessing care. Obviously, things related to patient safety and specifically impact on COVID-19 on care delivery. Originally, the survey, as a matter of fact, included 5 questions about COVID. In the end, in the final survey, they were dropped because by then it was less of a priority. But because of these very early days, that explains this request. And also questions related consideration of professional skill mix. And what you have in front of you now is the PaRIS framework, the resulting PaRIS framework. And let me take you through it a bit. So these are the domains that the PaRIS survey aims to capture. In green, you see all the domains that a patient reported. In blue, you see those that are more relevant, if you want, to the health system. In the upper left hand corner, you see health system design, policy, and context. This is a set of indicators that is currently, I mean, that was also developed, but that they are operate at the system level, and that you will not find yet in the report that we will that was already presented by Jandan Kendir in the first webinar that we organized, and or in the report as we will see also later. Delivery system design makes reference to the clinic and the healthcare professionals, and taps on a number of aspects that were collected in the provider survey. And finally, I set the 4 boxes that consider patient information, and which was patient reported. So individual and sociodemographic factors, health behaviors limited to 4: physical activity, diet, tobacco use, and alcohol use. A box that you will see reads health and healthcare capabilities, including digital domain, pretty much in the center, which aim to capture a constellation of domains related to health literacy, to self-efficacy, to patient empowerment, patient engagement, to patient activation. And in the process of constructing this, we realized that the literature was some of these concepts have been developed to a degree with independently of each other, and it was not straightforward, and certainly beyond the scope of our efforts to develop a sophisticated taxonomy of them. So we created this category, which is a container category, which is health and healthcare capabilities, basically trying to identify along this continuum of how patients would be able to contribute to and be in charge of their health and healthcare, continuing to how much confidence and how trust in their own abilities to impact on their health and healthcare, and finally, what's their productivity as well. But this, to a degree, only at a notional level. So we didn't clearly identify different boxes for this. So we left it pretty much as capabilities. And then the two more possibly relevant boxes, which are the patient-reported experiences of care and the patient-reported outcomes at the bottom. And patient-reported experiences of care, you will recognize a number of boxes. The first four correspond to the four cardinal functions of primary care: first contact or access, comprehensiveness, continuity, and coordination. People-centered care, that in the WHO vision document after Astana 2018 was also considered the fifth such construct, in which in our framework included individualization of care, decision-making, interactions with health professionals. Three more domains, which, as you will have seen, were specifically proposed by patients: safety, self-management, support, and trust. And then one which encapsulated an overall assessment of patient-reported experiences of care. So this is all in all basically how patients perceive care as received by them according to these different domains. Finally, at the bottom, you have patient-reported outcomes, which are measures of health as perceived by patients themselves. And they progress along a continuum from symptoms, so bodily experiences of health and disease, to functioning, so what people can and cannot do as a result of health in their daily activities, in their real life environment. Self-reported health, which refers to the synthesis, the distillation of all the previous one into a assessment of the individual of how they are doing in relation to their health. And then health-related quality of life, which is a more sophisticated concept that aims to focus on in relation to the quality of life of the individual. That is a part of it that is specifically related to health. And in terms of symptoms, also for your interest, we included pain, fatigue, shortness of breath, symptoms of depression and anxiety. And in functioning, we included the three classical areas or domains of health: physical, mental, and social functioning. So, and this pretty much set the scene for the what. So what we wanted to measure, all the things here in the PaRIS framework. If you are more interested in details about this, you will find the paper in the BMJ Quality and Safety, and it was published at the end of last year. And so you will find both this image, but also all the details about the development. Once we knew what we wanted to measure, the next step was to understand how we could possibly measure all these patient-reported outcomes, so measurements of health through the lens of the individuals themselves, patient-reported experiences, so how people report about receiving care, about capabilities, how people are able to make a meaningful contribution to the health and healthcare, and also the behaviors that are also quite relevant to understanding health and disease. So we organized, we wanted as much as possible not to develop any new instrument. Although at the end we acknowledge it would be still a survey, which would be a new one, but the different components, we thought it most efficient just to use whatever was available and then choose the best of it if we found it to be suitable. So, and that's why you see all these different components. I will take you very briefly through the rationale for each of them, and then in some detail through how we did all this. So the first one was to, okay, from all the existing instruments, which ones should we consider? So that was the identification of these candidate instruments. What PROMs, what PREMs, what other instruments are out there that could potentially be parts of PaRIS? Secondly, we shortlisted for each of the four uh, categories of outcomes, experience, capabilities, and behaviors, for each of them, four candidate instruments. So not one each, but rather four each. Okay. And then we, once we had shortlisted these four, we then completed in the third column a comprehensive standardized assessment. We will go in detail about what that means. Finally, we presented all this information to a modified panel. I mean, saying essentially, these are the four best instruments. This is what we have appraised them, and this is how they look like. What do you suggest in terms of how we put this together in a modified Delphi? And then event subsequently to turn this into the survey, as I was mentioning, the third component. So we had to translate all the instruments to conduct cognitive testing and do some piloting. So briefly let me take you through each of the boxes. So very much like we did for the framework, we also consulted the patient advisory panel, the technical advisory community, and country representatives. And in addition, in similar fashion, we also did a systematic review of each of these broad domains. This resulted in about over 300 different instruments with their different scales, different items that potentially could be shortlisted for PaRIS. Okay, then for all these 300 instruments, we compiled what items they had, what scales they were made up of, what was the scoring system, what languages were available for each of the instruments, what were the citations in Google Scholar of the core instrument, the core publication presenting the instrument. And with this information as compiled, taken from papers, from the websites for each individual instrument, through internet searches, contacting authors, we did a content mapping. So we went to the framework and said, okay, this instrument measures this aspect of PROMs, let's say symptoms and function, but not quality of life or not self-reported health. This instrument of PREMs measures patient-centered care, but doesn't measure safety or trust or any other variable. And also for each of these instruments, based on that information, we provided an expert evaluation to say, okay, this instrument looks promising or less so. At the end of the day, the people involved in this, we were experts in patient-reported measurement and were able to provide an overall assessment. And with all this information, we were able to have a weighted ranking, so that for these 300 instruments plus divided in different domains, we were able to rank them from best to worst using this weighted ranking and select the top four. But we were not satisfied only with the weighted ranking. We also wanted to reach consensus. So this means that we actually selected the top 20 in each, and then in discussion agreed which ones we wanted to shortlist as the top four. Now, For each of these top 4, we went again out to the literature and compiled all published evidence on the instrument development and psychometric performance. And we used that information coupled with a standardized approach for evaluating patient-reported information, which is called MPRO, which focuses on the um, evaluation of the measurement model, the validity, the reliability, the sensitivity to change of the instrument, how interpretable scores are, the burden of administration, alternative forms, so in terms of short forms, in terms of electronic administration, telephone administration. And with all that, we compiled summary dossiers for these 4 times 4 instruments for each of the 4 domains. And we fed that information into a Delphi panel, which was made of the 3 groups that we have already made repeated reference to: patient advisory panel, technical advisory community, and national contact points, who were responsible for implementation of the survey. And in a first round, the best instrument was selected. And unfortunately, it was very difficult to find a single instrument that would cover all of the PROMs, or a single PREMs instrument that would cover all the PREMs. Okay. After the first round, we went back to our Excel files and our mapping exercises and identified scales and items that would fill those gaps. And in the second round of the Delphi panel, there was at the end consensus on what looked like the best possible survey, combining all the different items, instruments, and tools. And we finally, outside of the Delphi panel, because that was made of a number of experts specifically recruited to the effort, we then also at the end of it fed that information separately to the different groups to ensure consensus. We then did translation, two separate translations, reconciliation of the 2 translations, and adjudication of differences. And then cognitive testing. In the first cognitive testing in each country, we, for each language, we tested that if there was any problem with the core survey, with the survey as proposed. And in the second round, we wanted to identify what aspects were more sensitive to linguistic differences, to particular localizations that would improve the quality, but were not really a problem of the core questionnaire. Unfortunately, because countries joined at different paces, the development process, this part was perhaps less straightforward and resulted in a very significant amount of work. But in the end, we were able to develop an instrument that we were able then to pilot. I'm presenting here to you the ICHOM, a collection of instruments, because to a degree also informed the development of this of the PaRIS survey. So ICHOM, as you know, is the International Consortium for Health Outcome Measurements. Is a collaboration between the Harvard Business School, Karolinska Institute, and the Boston Consulting Group for the identification of core outcomes for the management of different conditions. And some of the people involved in the process had also been responsible for the development of ICHOM. So some of the instruments that you see here, PROMIS, WHO5 index, and the WHO disability assessment tool were also seriously considered. And as a matter, as part of the identification process, but also fared significantly high in some of the different steps. So at the end, and for piloting, we had 118 items. And what you can see here is different for the you may will recognize the different colors that were you have seen previously. So above you have the sociodemographics. Most to your right, in the middle is the health behaviors. In the center is the health and healthcare capabilities. To your left, the experiences. At the bottom, the patient-reported outcomes. And these are the headings in the survey about yourself, managing your own health and healthcare, your experiences of healthcare, and your health. When you see a dotted line, a dashed line, it means that some items were taken from some surveys of these sources. Whereas when you see a continuous line, is that the instruments were taken as a whole. So, for instance, you see at the bottom WHO 5, which is the World Health Organization Well-being Index 5, and PROMIS 10, which you will remember from also of the ICHOM set here. And also you see here the P3CQ, that was the core, the spine of the health experiences. And although that was the pilot, the final instrument, you have it also on the website of the PaRIS OECD website. You have both the parents patient questionnaire and also the provider questionnaire. And they are available for if you have an interest in seeing what items in the end actually were made it. The difference between the pilot and the final instrument is not huge. Just a number of items, a very small number of items needed some small tweaking in terms of the wording, and then a very also a small number were also dropped to make the instrument more cohesive. And as said, you will find all the details here. The main metrics. So patient-reported outcomes. So people's perceptions about their health. The WHO Well-being Index, which is a measure of what is called psychological well-being. And you can read here on your left the 5 questions and response options. So over the last 2 weeks, I felt cheerful and in good spirits. I felt calm and relaxed. I felt active and vigorous. I woke up feeling fresh and rested. My daily life has been filled with things that interest me, with responses scale that goes from all of the time, most of the time, to at no time. So this is the WHO 5, I mean, one of the core metrics. Another one is PROMIS Global 10, which elicits not one, but 2 separate measurements, one of physical health and one of mental health. And it has, in addition, 2 more items that do not contribute to these measures. So items here, you have them to your right, and you have, for instance, item to one extent in the middle, global 06, to one extent are you able to carry out your everyday physical activities such as walking, climbing stairs, carrying groceries, or moving a chair? Completely, mostly, moderately, a little, not at all. Or further down, how would you rate your fatigue on average? Global 8, none, mild, moderate, severe, very severe. So that's the other main metric of patient-reported outcomes. And in addition, we will see now in the next slide, there are also some additional aspects, but this is the spine. The spine of patient-reported experiences is the so-called person-centered coordinated care experience questionnaire, the so-called P3CEQ, and it elicits 2 different scales, one for patient-centered care and another for coordination. Finally, there is also an instrument composed of 3-4 scale, depending on because these still some of these aspects are still under development. For the time being, I mean, in the report, I think mostly 3 scales are used. There's a chance, I mean, that there are also some arguments for using 4. And these are a set metrics of health and healthcare capabilities. I won't take you through the report, Does Healthcare Deliver? Results from Patient-Reported Indicator Survey that we have already revisited in the 2 previous webinars. It's, as you know, on the OECD website available for your perusal. But I will just, we're getting to the end of the presentation. I will take you just to this specific table because it's also important for clarifying what OECD in this report is highlighting, prioritizing as the core measurements. So these are the so-called 10 key indicators, the PaRIS 10. And these are made of 5 patient-reported outcome measures and 5 patient-reported experience measures. And as you can see, you have to your left in either green or blue the patient-reported outcomes. All 4 of these 5 are based on PROMIS 10, and they correspond to physical health, which is a scale, mental health, which is a scale, and social functioning and general health, which are individual items. And then you also have a measure of well-being, which is the scale corresponding to the WHO Well-being Index. On your right-hand side, you have the patient-reported experience measures. Again, 5, a set, 2 of them corresponding to 2 scales of the P3CEQ, coordination and person-centered care. And the other 3 correspond to individual items. So confidence to self-manage, in which you will recognize one of the so-called health and healthcare capabilities. Experience quality, which was one of the domain that tried to encapsulate the global patient-reported experience. And finally, trust in healthcare system that was both identified by OECD independently and patients themselves as one of the core variables. We've reaching the end of the presentation. I mean, all these, when I was saying as we, etc. So as you see, this has been a huge collaborative effort involving a very large number of people. There was in particular a consortium made up of these partners who was commissioned by PaRIS, by the OECD, to support the development of the framework, the development of the survey, including the translation, the adaptation, and also the administration, proposing also the plan of analysis and some preliminary analysis too. Well, all these people are part of the PaRIS SIR. We were coordinated by NIVEL, the Dutch Institute for Health Services Research in Utrecht, in the Netherlands, and other relevant partners were Ipsos Mori, now simply Ipsos, who you will know, which you may well know because it's one of the main companies involved in the administration of surveys. And then 3 other partners, the University of Exeter, in which I was based at the time. We were responsible for the development of the patient survey and metrics, and also for some of the countries, coordination of some of the countries, which included in the UK, England, that eventually did not take part, but Wales did, the US, Norway, and Saudi Arabia, for instance. And other partners including the Abedis Donepedian Foundation in Barcelona and Optimedis Hamburg in Germany, the non-for-profit. So I would like to thank you very much for your participation in the webinar today. You will be able to find here some links that provide more information in relation to the PaRIS initiative at the OECD and the consortium's website, and also some information about myself in case you shall find it of interest. So thank you very much, and I will very welcome now any questions that you may have. Because there are plenty of you, I would appreciate if you would raise your hand before asking any question. Thank you. Okay, I can see Maxine. Okay, let me see. Can I? Okay, please go ahead.
Yes, thank you very much for that presentation. I'm actually I'm joining from the University of the West Indies in Jamaica, and I'm just maybe 2 years into the patient centricity aspect, mainly through my work with the International Pharmacovigilance Society, specifically the North American chapter. I was just wondering, in terms of your tool, which is quite, intensely put together, is there any plan to have it validated in low middle income countries such as in the Caribbean?
Thank you very much, Maxine. I really appreciate the question because it's a highly relevant issue. When I was showing at the very beginning the slides with close to 20 countries, so these are OECD countries and they are all high income countries. So we made, for instance, in the patient co-development surveys, we aim to include also countries that were not necessarily that expanded the breadth. And although we did not specifically exclude anything that would be not relevant to lower and middle income countries, it is absolutely true that there was no, if you want, safety valve. So it was optimized for the delivery in the countries that were participating. So I'm aware the ultimate responsibility for future iterations of the PaRIS survey rests with the OECD. And as far as I'm aware, there is every intent, or as a matter of fact, the next iteration is already underway. And I know that they also want to make the effort to expand the mix of countries that will take part on this. So if you are interested in your country being part of this, I would very much encourage you to liaise with the relevant people in the Ministry of Health and lobby, because the OECD from the other end will be also trying to get your ministers of health interested in contributing to PaRIS too. There is also the possibility, of course, of undertaking some independent evaluation of the feasibility of using the survey as is in other countries. Nothing stops you from doing that. However, I think it would be a good idea to know if PaRIS is coming your way in terms of your country, because that may also mobilize some resources and combined efforts from the Ministry of Health that may very significantly facilitate that process.
Thank you.
You're welcome. Thank you. Luis, let me see if I can give you.
Yes.
Okay, perfect.
Hello, José Maria. It's a pleasure to see you again.
Pleasure.
Thank you for your lecture. It was amazing about the PaRIS patient questionnaire. As you know, I'm professor of digital health, and so mostly working on primary care. And so this is very interesting, and I appreciate very much the work you have been doing on the framework. It's excellent framework. I have two questions. They are much more or less related, but it's about I consider that one of the issues when we move from the standard model to the digital model, let's say it this way, it's on the service delivery design. And of course, it is very interesting to see how we can look at these aspects from the perspective of this framework. So how can we? The second question is related with this one, as I was just looking at the framework and the questionnaire, and the questions are, for instance, one question it's about the how the patient, how the service works. So if try to where it is.
I think it's probably from the P3CQ, whether the system works for you.
No, it's the questions you ask to the patients are, I'm not sure they are, if I know about the situation in Portugal, I'm not sure all the patients know how to respond. So most of these questions related with the health service delivery and aspects of the payment of the organization. I'm just wondering, how do you address that issue? Thank you very much. It was a pleasure to see you. Thank you.
Thank you so much. I appreciate it. So, sorry, running out of battery. 1 second. Okay, sorted. The issue of the different modes of delivery. I think that it is important to understand that this was a process by the OECD to setting things in motion. So, and the ambition is, the real value of this is in the longitudinal approach. So a cross-sectional approach, trying to compare countries and looking, trying to be very specific about, oh, this country is number 8, this one is number 10. I think I wouldn't necessarily go down that route. I think that the real value is, first of all, in internal comparisons, and then in broadly, I mean, in seeing where in, let's, if you want to say in terms of quantiles, deciles, where the different countries are, rather than me looking at different specific difference. I'm saying that because I think that the priority was to get something that was meaningful, but more than anything, to get this process started. And there is a realization that the survey will need more countries, other metrics, other domains as the systems themselves change. So it is very likely that the modes of interaction and the roles of, let's say, even artificial intelligence with the models that we cannot anticipate that may inform care may not necessarily fully captured by the current system. So we're in a pathway, and I think compared to the previous situation, it clearly signals a very significant improvement, but we need continue be paying attention to ensure to make it relevant. In relation to the local, the relevance to the individual patients, I can assure you that it's been one of the most strenuous process of ensuring that the system, the survey was applicable to patients, with the translation efforts, with the work with the multiple rounds of cognitive testing, and also the already identification a priori of instruments that were already available in multiple languages. Having said that, nothing is perfect, and there may be plenty of areas that can be improved. We used mostly legacy instruments. So if you want short forms, it's very standardized. Should this in the future be more like based on computerized adaptive testing, so that you can rely on a much larger set of items that can be tailored to the individual, that to ensure that you can select those items that work best in a country without necessarily having to ensure that all the same items are used. Yes, possibly. I think the efforts will be very, very substantial if that was the case, but certainly something to consider.
Thank you very much. Bye-bye.
Thank you, Luis. Okay. In the absence of any more questions, then let me thank you so much for your participation. I hope this was useful, not just this one, but the series that we had on the OECD PaRIS report. We by no means ruling out having future webinars. If you have any aspect specifically that you would like to hear about, I would be very happy to work with Jandan, the OECD team, and others in the Working Party to see how we can make it useful for you. Also, if you're attending WONCA in Lisbon, we will be having a workshop with our president-elect, with Jandan Kendir at the OECD, and with myself, in which we will be revisiting some of the core aspects that have been presented in the series, also on the day, also for your benefit. Okay, thank you very much for your attention today. And sorry, I'm just checking the chat just to ensure. Just thank you, and have a very good morning, evening, and for me, night. Bye-bye.
Bye-bye. Nice to meet you, Tema.
Bye.
Thank you very much. Thank you.